Peripartum seizures are a part of our headache. It is a mountain to climb. Whenever we get such patients, we are worried about the outcomes. And when we succeed in getting a good fetal outcome, along with a healthy mother, it is joy personified. And that is why I think we are interested in today's session. Again, you'll find that peripartum seizures in obstetrics, some are before, and as you see, some are after. Now, they have certain combinations, and most of the time we have found that, the new onset seizures at the time of childbirth have historically been attributed to eclampsia till proved otherwise. We have a high index of suspicion because that has had, because of the endothelial changes in the blood vessels, etc., the uterine development, everything, they have got a big impact, and we are very careful about that from the very beginning. And that is why this group, even before they go into convulsions, usually our attention is brought to them, and we investigate them and manage them from the very beginning. Well, there are other causes of peripartum seizures, and a mother who has been epileptic and is now expectant mother. We remember the treatment has been going on for some time, and while we have thought about the implications of the drugs and its effect on the fetus, we have to keep in mind the physiological factors that as the fluid retention occurs, the therapeutic blood levels may go down and the mother may go into a convulsion. Again, subarachnoid hemorrhage, intracerebral hemorrhage, these can be very good causes of peripartum seizures, and we have to have a high index of suspicion. In fact, people who work, sometimes obstetricians and gynecologists are not very much aware of what is going on, and they tend to rely on us. Otherwise, everything they label as eclampsia. We have seen patients who have had a ruptured berry-aneurysm, immediate post-caesarean section, and the first occasion they were treated as a patient with eclampsia. And then on the second event, during the second pregnancy, again, before that in the interim, they had been investigated. Nobody thought of neurological causes. And ultimately, in the second pregnancy, because we have a high index of suspicion, those of us who have worked with neuroanesthesia, etc., so then we said, no, you get your self-investigated. And they came to know, but after 6 months, they knew that they had a berry-aneurysm rupture the last time. And then they have got a very high incidence of rebleeds and high mortality rates in that period. And the convulsions have got very grave significance. These patients can be victims of thrombotic thrombocytopenic purpura, amniotic fluid embolism. I think the amniotic fluid embolism, all of us have had seen at least 1 or 2 in our careers. Then we can see cerebral vein thrombosis. We forget sometimes that intracranial neoplasms, etc., can coexist at that time and be discovered also at that time. And head trauma is a concomitant thing that can occur at any time, and idiopathic epilepsy. Now, a very interesting thing that comes up is the reversible posterior leukoencephalopathy syndrome. I will be talking more about it, but this, if you should have an index of suspicion without which it may not be detected. It may just occur because of the bilateral edema, which may be difficult to trace on a normal CT scan. Again, fluid retention, if it is combined with a lot of water intake, the margins of safety are less, and water intoxication can be a cause, especially if 5% dextrose has been given. Historically, in the early 1940s, they thought that in the postoperative period, surgeons had a very high worry about the salt retention, and they used to give 5% dextrose for everything. And it has gone down to surgeons of various departments, specialties, whether it's obstetricians or general surgeons or orthopedic surgeons. And very often, even today, we have seen that patients are given 5% dextrose, maybe irrational, but they're given. And I have been called to treat intractable seizures, and I have found that they have had severe hyponatremia. And we can have the toxicity of anesthetic agents may also be one of the causes. Again, in certain individuals, abrupt drug withdrawal. Again, pregnancy may and very frequently does occur in mothers who have had high-risk behavior and may have HIV. That also has got suspicion that sometimes they have direct effects on the central nervous system leading to convulsions. At the same time, drug abusers, especially when they are coming towards the end of pregnancy, they become more conscious about their child and they may develop withdrawal symptoms at that point of time. Again, it has been seen in certain individuals, stress, sleep deprivation due to maybe other causes, maybe social causes, anything, and these may affect them and precipitate a seizure. But coming back to the previous one, eclampsia was the commonest and was estimated to occur in 1 in 200 cases of preeclampsia when in such patients magnesium prophylaxis is not administered. Many drugs have been administered for the treatment of preeclampsia, and even today, in trying to prevent the convulsions, many factors come up. One is availability, one is cost, and sometimes, we are all anxious to try new drugs. But if we look at it, the magnesium sulfate has got a very big role. But when the patient comes to us with preeclampsia, we have to ensure that we are monitoring the patient properly so that we are checking their renal function, the fetal growth and well-being, and detecting when the patient is becoming severely preeclamptic. The blood pressure systolic is shooting up to more than 160, diastolic more than 110, measured at 6-hour intervals. We are seeing that the protein is more than 5 grams or maybe 3 grams at 6-hour intervals. So we have to see that we have to control the blood pressure, and preventing the seizure becomes a very, very important thing when to institute the magnesium sulfate therapy. And on confirming the diagnosis of severe preeclampsia, or in the context of severe preeclampsia, one's decision to deliver has been made. We seem to be very, very afraid of magnesium sulfate. It is a very simple drug. It is a very commonly available drug, but it has been the fear sometimes of any theoretical aspect, and we go overboard in saying that we can't use it, forgetting that all the other drugs that we use, they may be more exotic, but they have also got a lot of toxicities and they have their own side effects. But magnesium, it is the poor man's drugs which seem to face the maximum criticism of their side effects. Whereas very simple tests can do it. But yes, no, we are all the time worried about serum levels of magnesium, and if we cannot measure serum levels of magnesium, we tend to avoid the use of it. So very important in these patients would be the timely delivery and care of the term and preterm infants to prevent their morbidity, and postpartum vigilance. Now, we have seen that while many trials have been there, choice of hypertensive agents, we have seen that no clear differences between many of these drugs, the methyl dopa, labetalol, nifedipine, not much difference. Again, hydralazine may have the advantages due to low cost, but not much clear differences in them. So, again, we have seen that what is more important, besides the theoretical risks of what could have happened, treatment of the preeclampsia appropriately, and when the maximum usage, big studies have been done, prophylactic magnesium sulfate halves the risk of the convulsion and probably reduces the maternal death, appears to be safe for the baby. And in the doses that were used in the study conducted by the United Nations USAID, USAID program, they found that about a quarter of women who have the side effects in the dose used was largely the unpleasant side effects rather than the serious ones. And while the Royal College of Surgeons has been recommending magnesium sulfate very strongly, the Australian college, they recommend magnesium sulfate only in severe preeclampsia. It has not recommended this therapy in cases of mild preeclampsia. When we are trying to diagnose eclampsia, focal neurology and specific changes on imaging, though some amount of changes may be present, you might see some edema, but the specific changes to eclampsia, you don't have such specific changes most of the time. Now, treating eclampsia, importance of this is, the price to be paid is very high if we delay. And therefore, the sooner the treatment starts, the better the survival rates. Let us not forget that in this country, our maternal mortality rates are horrible, they are shameful. While we are trying to be purists, we are not trying to carry the message home that the maximum benefit to the maximum population has to be ensured, and our maternal mortality rates are just one of the world's worst. Sometimes we compare with Africa or below. We should not be only ashamed, we should take this as a message and start to think of what should be better. In some instances, Bangladesh, they have less shame and they carry on taking corrective steps and sometimes they prove them. In one of the disaster management meetings, I found that they had achieved a 400-fold improvement in their mechanisms in disaster management, whereas in our country, we still continue to repeat everything ad nauseum in every part of the country, whatever type of disaster comes, and the same disaster is with maternal mortality rates. So, if we see the treatment is relatively simple if instituted immediately, then this, with its effect on the control of the blood pressure and the delivery, reduces the maternal mortality rate. Now, delayed treatment, especially beyond 2 hours, may lead to the patient requiring more intensive care and for an admission to the ICU for treatment of shock or DIC or renal shutdown. There may be respiratory failure, there may be sepsis, and there may be multi-organ failure. So once this happens and the patient comes to an ICU, even in the best centers, the mortality is high. So can we ensure immediacy of treatment, and especially in a country where many births are occurring at home and where skilled care is not available? Where I come from in Meghalaya, the patients refuse to come to the hospital, whatever the reason. Now, treating eclampsia, there have been a lot of studies comparing the effects of magnesium sulfate and diazepam on a large number, and they have found that there has been a 50% reduction in the recurrence of convulsions. For every 7 women treated with magnesium sulfate rather than diazepam, 1 case of recurrent convulsions was prevented. And there has been a reduction in mortality, and the Apgar scores have improved. And these are things that are something that we should appreciate. Even if we look at the experience of Dhaka, with a single dose of magnesium sulfate, they couldn't give too much. They said, okay, even a single dose of magnesium sulfate administered to these patients, the efficacy was that they have given the loading dose versus the standard regime, and the recurrent convulsion rate came down. And the majority of the patients, even a single loading dose alone suffices. And this simplified treatment makes it possible to treat eclampsia even at home. And for our country then, what does it seem? It seems to be the right thing to do. And this study was conducted with the help of the USAID program. Again, in our own state, in Bengal, we can see the use of magnesium sulfate and the case fatality rate in eclampsia came down very much over here from 19.12 to 7.57. And this program trained our medical officers and nursing personnel and achieved something that is, I think, making us feel, yes, there is something we can do. So what is important is these patients should be monitored regularly, and their regular assessment of the urine output, the maternal reflexes, the tendon reflexes, the respiratory rate, the oxygen saturation, and careful monitoring of the blood pressure and measurement of the 24-hour urine protein. And just ensuring that liver function and kidney function are okay. With the liver function, we reduce the incidence of the health syndromes, and monitoring treatment should continue postpartum, because very often postpartum convulsions continue to occur even 20, 22 days later. So how costly is all this monitoring? We have to think. How does it impact on the cost effectiveness and practicability of this intervention? These are things that we should have more studies on. And while we are all talking of data from our country, at least we start these simple things and see how much does it have a cost-effective effect? Does it improve our mortality? These simple things will reduce the mortality in these patients. Many drugs have been used. Carbamazepine, trimethoprim, valproate. You see, they have not been found to be very, very useful. Again, the newer drugs have been also used, and these, they are, in fact, none of the existing studies revealed a rate of congenital malformations that was more than for a woman with epilepsy who is not taking anti-epileptic drugs. Imagine. And we are giving them, and we are thinking that we are doing something good. Then the clinical frequency, the management of the seizure frequencies, the close monitoring of the anti-epileptic drugs. I have mentioned that these patients, we have some studies need to be done to ensure that the total levels of the anti-epileptic drugs in the blood are maintained. But it is very important to check the free levels in patients who are difficult to treat, patients who continue to be having convulsions, because while the total level may be okay, it is the free levels that may be low and the efficacy may be low, and that the free levels may be needed to be monitored monthly during pregnancy with adjustment of the dosing based on these levels and the clinical manifestations. So I was talking about the other one was the reversible posterior leukoencephalopathy syndrome. Again, the patients present with headache, focal visual abnormalities, seizure. But here it is that the sophisticated investigations have a role to play. So MRI findings typically are consistent with vasogenic edema, most marked in the posterior. If we are to make a diagnosis and a differential diagnosis with eclampsia, they're most marked in the posterior parieto-occipital white matter and the corticomedullary junction. They may also involve the cerebral cortex, brainstem, basal ganglia, frontal lobes, or cerebellum, especially with the use of fluid-attenuated inversion recovery imaging. Again, diffusion-weighted imaging allows differentiation between vasogenic edema and infarction. CT scanning can also be used to show the edema, but they don't always give us very good diagnosis. But the good thing about this particular condition, this convulsion, is that if we detect it early, treat it early, then the mortality rate is not there. The findings resolve, even the MRI findings, they resolve on antihypertensive treatment because it was an edema which was not allowed to progress unbridled. So this condition is still under-recognized and therefore under-treated. So imagine if we have a treatable, potentially treatable condition and the patient recovers fully, it would be a crime not to treat it in time. And if the treatment is delayed, irreversible changes can occur, but the incidence in the peripartum setting is not known. But this should be considered in patients presenting with headache, vomiting, confusion, seizures, or focal, visual, or motor signs in the presence of a precipitating factor. Sometimes, that even an eclampsia may precipitate it, or other conditions can precipitate it. So it needs a differential diagnosis, but at the same time, preeclampsia can be a precipitant factor, and management consists of careful control of the blood pressure, maybe with nitroglycerin, along with anti-edema drugs, steroids, and most common causes are hypertensive encephalopathy, cyclosporine A, neurotoxicity, and uremic encephalopathies. And the postpartum women have the risk of developing it even without the preeclampsia, and vascular endothelial dysfunction may trigger it in addition to the increase in the blood pressure. So as I mentioned, that management of convulsions, peripartum seizures are fraught with difficulty and danger as in climbing the mountain, but once we can steer the patient and the fetus through it, we have a result which keeps all of us happy with a feel-good factor. Thank you.